So let's move into the Q&A session. I see that there are still on Slido a few questions about yesterday's day, the brain day, and I would suggest that we leave them for the end in case there are no other questions. So the first question I see is for Monique. Why should a case of transposition show crossing of the arteries at the outflow tract views?
Yes, the case that I showed, and I have several cases in transposition, and that is what people, I think, not realize. The spatial orientation of both outflow tracts may differ. So they can stand in the transverse plane of the chest, they can stand very parallel, but they also can move a bit. And I always use my arm to explain that. So not every transposition case, one transposition case or the other, can have slightly different pictures. And that is the case, and I saw that the video was blocked a bit. I think with the export to the movie, there went something wrong. In the case that I showed, that was a transposition case. And in some cases, the aorta is so much towards the right side in the right ventricle that in the area above the heart, they somewhere have to go both to that descending aortic arch. And in that plane, they sometimes are a little bit like this. And I think that was perfectly visible in that video clip. At the end, it ran. So what I really mean with that message is you should look at a three-vessel view, you should look at a three-vessel trachea view, both of them. And if you cannot get that plane, then just refer. Don't try to diagnose yourself. And this is meant for people who are working really in a low-risk screening setting. So that's not meant for doctors working on a prenatal medicine department. Then you should refer. And what I saw a lot in studying missed cases, and I've seen now, I think, over 120 cases of heart defects that were being missed in screening settings, is that, and that is a consistent finding, that at the end of such an investigation, you see a lot of pictures that ultrasonographers are seeking the right planes, and at the end it is consistently ended with one or two more or less normal images. And I think the psychology behind that is that ultrasonographers at the end, they are doubting, but they are not able to diagnose what is wrong, and they see that it is not normal, and then at the end they comfort themselves with one or two, maybe three normal planes, and then they comfort themselves and they are saying, now this aortic arch is normal, or I see some kind of crossing, and I have learned that in transposition I should see parallel vessels, and I see some crossing, so it's normal, and I end my examination. And I really think that is the psychology behind missed cases.
Well, it may also be that to look for parallel vessels is one of the most difficult views.
Exactly.
That we, in case of transposition, should look for other easier landmark sign. What the other panel members think?
Yeah, I agree wholeheartedly, Katja. And I think, as Monique said, it's the particular type of TGA where both vessels come out in an anterior and posterior position is only quite a small proportion, in fact, of TGAs. Therefore, you have to rely on only seeing two vessels on the three-vessel tracheal view, which I think is probably the most powerful sign. And then the reversed convexity of the vessel coming out of the right ventricle. You're surprised, you sweep from the right ventricle, you see those vessels going in a very abnormal convexity. And I think if you go back to the actual, I think it was Masudi, I think he was a pathologist, described in dextro TGA, which is most of them. The levo is the congenitally corrected. So the far more common scenario of the dextro TGA, that position of the aorta and pulmonary artery directly on top of each other actually is only in about 10% of transposition of great arteries. So for the vast majority, then 90%, there is not that parallel relationship at all. The most common type is, in fact, that the aorta is anterior and to the right of the pulmonary artery, and therefore, yeah, it's a lousy sign, I would say. I say the parallel vessels, to me, is the weakest sign if it's representing only 10%. And then you consider all the other. There are 5 different types of TGA in the relationship of the aorta to the pulmonary artery. You cannot rely on it. And Monique also made the point that you have to get an oblique section, which is not part of the standard issue or guidelines. So even for the 10% of TGAs, I would say really put that on the sideline and look for 2-vessel and 3-vessel tracheal view as being a very powerful marker. The reverse convexity. And the third marker is as part of a routine screening exam in ISIOG, when you sweep up from the 4-chamber view of heart, the first vessel that you should always see is the aorta. And if you are sweeping up and you see a vessel that bifurcates, you're seeing the pulmonary artery first, then the penny should drop for you. So I think there are the 3 key signs, and I put the parallel vessels right at the bottom. Yeah.
Great.
Fantastic. I think there is a question from Katia. So, dear Professor Bilardo, if you are switching from US assessment on Down syndrome and screening and NT measurement to an anomaly screening, do you think ultrasound before 12 weeks should be banned? I don't know.
Not at all. I think that ultrasound before 12 weeks it gives very important information. Well, we have also to look for location of pregnancy, number of fetuses, and a lot of other information, and whether the pregnancy is viable. And so these are very, very important information that we need to get. I think that a very tricky issue is which is the best time to assess gestational age, because in the Netherlands we tend to use the first scan to assess gestational age, whether I'm personally convinced that you can also perfectly assess the gestational age at 12, 13 weeks. And then there is also the other aspect that the group of Simon is really pleading for this pre and IPT scan as a first moment of assessment of fetal anatomy. So maybe, Simon, you want to comment upon that. I really think that if it's strictly an anatomical scan, then that should be done preferably from 12 weeks and 3 days afterwards, and not before that, in a screening context, and not in a center of excellence context. But I really think that to have a look at the pregnancy before 12 weeks is still mandatory.
Yeah, I agree with you, Katia, 100%. And in fact, I think there's a stronger impetus to pursue first trimester anatomy scan than ever before. I would say the reverse to what the question is maybe suggesting. And that, in a sense, comes from the more recent data in the last 5 years, suggesting that structural abnormality has got a strong association with gene mutations, monogenic disorders. And in fact, if you look at the additional yield for all abnormalities, there's a 30% additional yield in doing wide exome sequencing. And the earlier you make a diagnosis in pregnancy, the earlier you will get a result. Because as we look in 2025, there is a cascade of investigation that starts from the point of making a diagnosis of fetal malformation, offering an invasive test, FISH, chromosomal microarray, wide exome sequencing, and then possibly down in the future, whole genome sequencing. So that's a cascade that takes time. And currently what's happening in 2025 in most units around the world, a diagnosis of a cardiac abnormality is being made late in the pregnancy at 20 weeks of gestation. And by the time you get the result of your wide exome sequencing, you're 27 to 28 weeks. That's very late in the pregnancy to be giving any woman a diagnosis. You want the diagnosis of a cardiac abnormality in the first trimester of pregnancy for those patients where they want invasive genetic testing. And by the time you have your cascade of investigations, you have a result at 17 to 18 weeks. That, for me, is a huge difference to providing a woman with a monogenic disorder result at 26 to 28 weeks gestation. So I would say we need to push to make these diagnoses early in the pregnancy if we're going to adopt that approach of cascade of investigation. On the flip side, there's always the scenario of making a diagnosis for, are you prolonging somebody's agony in the scenario where somebody's going to continue the pregnancy in providing the information so early? And I would say it's always difficult. And I think I always concerned about that group. But I will always say that, in a sense, bringing in a multidisciplinary group and approaching, getting everything prepared well in advance, the earlier you start that process, I think the better. I don't know if everybody in the panel agrees with me on that, but that's probably my take on it. And lastly, Katia, yes, we do a cell-free DNA at 10 weeks. It's almost another discussion for another day, I think, really. But I think, yes, we offer that at 10 weeks, and we find that very valuable when we do an assessment at 13 weeks and we find, say, soft markers, an intercardiac echogenic focus, an aberrant right subclavian artery, a persistent left superior vena cava, pericardial effusion, and we say, look, listen, we know the cell-free DNA is low risk, and if I have an aberrant right subclavian artery, how I cancel that patient is so reassuring so quickly at 13 weeks. I don't create any anxiety as opposed to picking it up as an anatomy scan at 13 weeks and then going into the whole thing. I find it's easier. Yeah, I'll stop there.
Just one question, Simon. It's something personal. So do you have a personal preferences for doing a scan at 12 compared to 13, or according to you, so that the accuracy of ultrasound is similar? Because of course at 13 is personally is much better than 12. Of course, is better than 11. So we are moving to an anatomical assessment rather than assessment of just the nuchal translucency, other subtle marker. So do you think that we should move on our assessment later on in the first trimester?
Yeah, look, I think there's different people do different things, and it's hard to know what's the right way of doing things. I think there are so many different ways of screening. Yes, personally, you ask me personally, I'll say, yes, I do have a preference for 13 weeks. But, at the same time, there are many different healthcare systems with different algorithms of screening. And in a sense, what works locally, I guess, for particular healthcare units is maybe the best. But if you ask me, if a patient comes in and you look at to answer your question directly, Francesca, which is a really good question, is the detection rate at 12 weeks is better than 11 weeks. And the detection rate at 13 weeks is better than 12 weeks. And the detection rate at 14 weeks is better than 13 weeks. And that's all the study, original study was by Rizzo and colleagues. So we know that for each week of gestation from 11 to 14 weeks, that the detection rate is better. It's a linear increase in detection rate. The problem with 11 weeks is it's just too early in a sense, and your detection rate is too low. The problem with 14 weeks is your detection rate is too late. So it's somewhere between 12 to 13 weeks is probably what I would say is the best time. The advantage of our algorithm of screening is that because we've done cell-free DNA at 10 weeks, we precisely time the scan so the patient is exactly 13 weeks. And that's, as I see, as being a major benefit of doing cell-free DNA before the first trimester scan. Because if you say we're going to do an anatomy scan 11 to 14 weeks, then do cell-free DNA, well, you'll find 10 to 15% the dates are wrong, Whereas if you do cell-free DNA at 10 weeks, you get precise dating the pregnancy. And yes, the detection rate for me is the 13 weeks is the ideal time. But, that's a personal opinion. I'm not saying that necessarily that translates what everybody should be doing. As I say, there are different algorithms and different things work for different people across the globe. I hope that answers.
But I think that many people will agree with you, and I personally do.
It also depends on cost, I would say.
Yeah. Yes, of course, it depends on cost as well, particularly when you were talking about doing a scan pre and IPT, Monique, Yes. That's an additional cost to a healthcare system. I mean, how many healthcare systems around the world are going to support doing 3 routine scans, and now we're talking about a growth scan in later in the pregnancy, 4 scans per pregnancy. Certain healthcare systems can afford 1 scan, you know. So it does depend on what the healthcare system can provide. And Australia, in a sense, is a first world country with a strong healthcare system, you know, and offering a pre and IPT scan at 10 weeks, an anatomy scan at 13 weeks, and an anatomy scan at 20 weeks, and a growth scan at 34 weeks is something, 32 weeks is something that, some say 36 weeks, is something that our healthcare system can support, and increasingly that is what has been offered. But yeah, certainly that is not a global healthcare system.
Absolutely. Yeah. I would like to ask Monique her view on the use of a transvaginal scan, especially in the first trimester, obviously.
I'm a huge fan of transvaginal scanning, and I regret that it's not that used so much in my country, I must say. I have so many numerous examples of things that I could not see transabdominally, and you swap early in your examination, you swap to transvaginal scanning, and you have the images nowadays with modern machines are almost comparable to a 90-week scan abdominally. So yes, it is more difficult, and you have to be patient, and you have to adjust your machine to get your views that you want. And sometimes fetuses, you cannot get the transverse plane because head is first or buttocks are first. But in general, if you have a little bit patience, and you also, if you manipulate a bit the transabdominal, the womb and the position of the womb, you can get so beautiful images, and they are so very informative. Yes, I'm very much fan of transvaginal scanning, but in daily practice, I don't see it used that much. And I regret that, yes.
Yeah. Would you dare to say that every time we do a first trimester scan, and this is a question for all of you, and we are not satisfied about the image of the fetal heart, we should use the transvaginal approach?
Oh yes, we have now, and you know that that I am and you are in our group as well in the Netherlands. We performed an implementation study for screening in the first trimester, and I was really not so happy seeing the results for the detection of cardiac defects in the first trimester. And I'm setting up a similar study now on the heart defects to look at the images. But I already saw, I think, 10 to 12 cases, and the image quality is not good enough. So if you cannot get a proper 4-chamber view in the first trimester, move to transvaginal scanning early in your examination. Because again, talking about psychology in the ultrasound room, I think what I saw so far, but that is not science yet, that is just case studies. What I saw so far was that there are multiple attempts within the half an hour that ultrasonographers have to perform their first trimester anomaly scan, and that at the end of the examination they conclude that the images are not well enough, and then they are then they have time pressure. So I think if you are early in your examination and you see that the image quality is not good enough, go to transvaginal scanning early in your examination, and don't use your complete examination time and then conclude that the images are not good enough.
Yes, I fully agree. Well, obviously, in different countries, there are different settings. In the Netherlands, really the screening is done by sonographers, and there is a referral system whereby when there is a doubt or a suspicion of an anomaly, there is a referral. I'm aware of the fact that this is extremely variable worldwide. So Simon, Francesco, do you have anything to add?
Yeah, there is another question for Simon, which I think is quite controversial, so I don't know which it is actually. So let's say, so Simon, quite impressed by the array of the anomalies you can pick up in the first trimester. I'm curious to know the outcome, especially TGA, tetralogy of Fallot, and even VSD. I don't know whether it's in terms of associated anomaly, genetic anomaly. So of course we know that the outcome of this condition is much worse when we identify this in the first trimester. So do you notice any difference in the outcome? I think so the question is intended to be related perhaps to the occurrence of genetic anomalies and association with other anomalies.
Yeah, I think you've sort of put the finger on it, Francesco. In a sense, you've sort of almost answered it for me. Yes, I think if you look at it, first of all, the prevalence of cardiac abnormalities in the first trimester is much higher than it is in the mid-trimester. And we see many cardiac abnormalities that are associated with other structural abnormalities. So you'll find a cardiac abnormality on an omphalocele or polydactyly or a facial cleft lip or a two-vessel umbilical cord or a duplex renal system. And you're dealing with a multi-system anomalies. And then you go down the pathway of invasive genetic testing. They never see a pediatric cardiologist. So there's a high volume of patients that have come through who have a cardiac abnormality. And what we now know is that once there is an extra cardiac abnormality, that 1 in 3 of these will have a gene mutation, which requires exome sequencing. For the group that are isolated cardiac abnormalities, in terms of making a diagnosis in the first trimester, what is the outcome? Answering the second part of that question. In a sense, it's very similar to what it is for the diagnosis that's made at the mid-trimester of pregnancy for many patients, particularly the two that you've just mentioned in that question, transposition of the great arteries and tetralogy of Fallot. So for both of those operations, there is a general rule, a single operation repair. When I say tetralogy of Fallot, I'm talking about the majority, the 75 to 80% that have a recent sized PA. I'm not talking about a TOF with a pulmonary atresia or absent pulmonary valve syndrome. So for those two abnormalities, they are a single operation repair and carry a very good prognosis. So most patients in our unit would choose to continue their pregnancy. And again, I make a very important point. I'm an obstetrician. I'm not a cardiologist. So I don't counsel the patients about the prognosis for these. I do a scan with the pediatric cardiologist in the room with me. And it's the pediatric cardiologist who counsels these patients about the outcomes for the pregnancies. For the more complex abnormalities, for the univentricular hearts, well, let me start with the cardiac extrophies and those ones. These are severe for most patients. Very, very few of those will continue with the complete extrophies. Then you come down to the univentricular hearts. The difference would be, in a sense, in the first trimester when compared to a second trimester diagnosis, that many patients we recognize that when an abnormality is picked up, and Katia, I think, has got good data to support this, where the abnormality is picked up early in the first trimester of pregnancy, that's with the severe cardiac abnormalities, the patient may choose not to continue the pregnancy. So in that sense, there may be a difference to making the diagnosis in the first trimester, whereas compared to making the diagnosis in the second trimester. So I can summarize and say, 1, cardiac with extra cardiac abnormality, never see a pediatric cardiologist. 2, the group that have a good prognostic group, we counsel them in a sense very similar to what we do in the second trimester. And then those with a severe or poor prognostic group, for those patients after detailed counsel with pediatric cardiologists, a much higher proportion will choose not to continue when compared to the second trimester. I'm hoping that answers the question.
Yeah, completely. Absolutely. Let's see whether there are other questions. Of course,
there is a last question for Monique, and that is, what is the added value of the 3-vessel view in comparison to only the 3-vessel trachea view? In the Netherlands, we have to make also an image of the 3-vessel view.
Yeah, I think that is an easy answer, and I think Simon already addressed that very well. I think in his lecture, the 3-vessel, now I have to look that I say the right wording, the 3-vessel view also encompass the position where the pulmonary trunk comes out of the right ventricle. So that upper part of the right ventricle is called the conus. That part should be visible in the 3-vessel trachea view. And especially for the sonographers in the Netherlands who undergo a yearly, biannual monitoring of their images, I think we should not think too much in separate planes. You should connect all those planes and make a sweep. And I'm a strong advocate in my country to move from only looking at separate planes and swap to save a sweep from four-chamber view to right ventricle outflow tract to three-vessel view to three-vessel trachea view. Because those images can differ much. For instance, pulmonary stenosis with an only minimal enlargement post-stenotic dilatation. And if you go up more, then you come into the three-vessel trachea view that might be gone. The three-vessel trachea view, as I stated in my lecture, and Simon told that as well, is so important for coarctation, for aortic arch hypoplasia. So those two separate planes are very important to look at them both. So don't leave out the three-vessel view because you think the three-vessel trachea view is important enough. No, I really disagree with that. And again, I cannot stress that enough. Don't assess the heart in just four separate planes. Make a sweep and put it in your mind as a three-dimensional organ.
Don't you think that this is a limitation of the system that, at least in the Netherlands, we use to assess the quality of the investigation? I suppose that probably in the future with AI, and we may be able to use, instead of steady images, video clips, and then that will certainly contribute to the reduction of missed anomalies the moment that we will be able to do that.
I had a few slides about AI in that presentation, but I already went over my time, so I deleted those ones. I fully agree with you. AI will solve, I think, partly that problem. But on the other hand, if people lose their feeling of the spatial assessment where they are in the heart because they cannot get their normal planes, then it might be the case that AI gets into trouble as well, because the normal good planes are not being made. And a second thing which a good study should assess, if AI maybe could produce a lot of false positives. That we do not know. We at this stage in science, we do know that AI can detect abnormalities, but what it will mean in sense of false positive, that is really a subject for a study in a real life clinical setting. And yes, again, I think the monitoring system in the Netherlands is good because the quality in general, we have 85% detection rate for transposition, and that is quite good. There are not so many healthcare systems that can produce 85% detection for transposition, so we should not be too negative about the Dutch system. But on the other hand, the quality system, I think, needs an update. Only monitoring for stills, I think that was good 10 years ago, but that is not good for 2025, I would say.
Good. We are nearing the end of the session, a very interesting session. I thank wholeheartedly the excellent speakers. And we will be back at 11:40. So you have 10 minutes to grab your cup of coffee or or something else for you, a gin or a whiskey, Simon. I don't know. Anyway, see you in 10 minutes. Bye-bye.